Hi, everyone. Welcome to the Becoming Anchored podcast. My name is Laura Deneen, and I have the lovely Amy Mary Askin on the show with us today. So thank you so much for being here, Amy. It's a true honor and joy just to work with you and call you friend and colleague. And so I'm so glad that our listeners have the privilege of hearing from you today.
Oh, I'm so excited about this, and it's always such a pleasure to speak with you. So I'm looking forward to it.
Same. Well, if you're new to the show, welcome. Lauren and I started this podcast a few months ago, and Lauren had the idea last year, and I jumped on board. And it's really just been such a fun, fulfilling activity for us. And we also get to talk to people in our Nashville community that we just so look up to and enjoy speaking with. So it's just been such a fun thing for us to do. If you are new to the show, really the purpose of the Becoming Anchored podcast is to ride the waves of life with you all. So we talk about hard things on the show. We talk about our own grief and pain, and we also talk about things that we're celebrating or victories. And so really we are human first and foremost with you all. But then we also have the amazing gift of sitting with clients every day. And so we also share some of the wonderful stories that we have heard over the years through our own therapeutic experiences. So we're so thankful that you are here with us today, and I'm just so glad to have Amy on the show. Just a quick disclaimer, this is not therapy, and so if you are local to Tennessee, please reach out either to us at Anchored Counseling or to OCD Nashville, and at the end of the show, Amy can share more about her practice, but we would love to see you. And we're located, we're actually neighbors. So you're right, your practice is right up the road from us. So we're located just south of Nashville in Brentwood, and we would love to see you. And if not, we encourage you to reach out to someone local to you. So we are going to be talking today about all things OCD and OCD recovery, and this big, Amy and I were trying to decide what we wanted to talk about, and I was kind of between 3 or 4 topics. And so we are just here to talk about the world of obsessive compulsive disorder. And Amy is really a true expert on this and really looked up to in the field. And so we are certainly blessed to have her here on the show today, and even as a part of the Nashville mental health community. So welcome, Amy.
Thank you so much. It's I'm actually doing the work right now of not allowing my imposter syndrome to come out and correct you about some of these words like, oh, expert or things like that. So, hey, I'm doing the work here. I'm glad to be here.
I know. I'm that way too, where I'm like, sometimes I walk into the office and I'm like, what do I actually know? Do I know anything? But right. You do. And yeah, you are an expert. And I understand as well that it can be hard to receive that affirmation and to really just soak that in and claim that, if you will. So I'm just curious, I would love for you to share a little bit more about yourself, about the practice and the type of clients that you guys see.
Mm-hmm. Thank you for that opportunity. We've been open. So the name of our practice is the Nashville OCD and Anxiety Treatment Center. A lot of people also know us as OCD Nashville because that's kind of our social media presence on Instagram and Facebook and places like that. And I got into this field to back way up, I was in a PhD program for psychology and really thought that I was going to likely be a faculty member somewhere, doing research, doing academic work. And then I was in grad school. 2 things happened, one after the other. Number one is that I got a diagnosis of OCD myself, and I had symptoms since I was about 6 or 7. Just didn't really know what they were. That happened, and then right after that, I was given my first opportunity to work with a client with OCD, and I was like, "Uh-oh, here we go." Speaking of imposter syndrome, right? I became fascinated with this field and this work. And I find the treatment of OCD to be endlessly creative and collaborative and effective. And so I ended up getting my degree, ended up doing some research in the area. And since then, it's really been my passion, and I haven't looked back. And I do consider myself somebody who likes to do a lot of different things. So I think, OCD affords that amount of variability day to day. So I opened up in 2018, I opened up this clinic, and we have grown. We have one location in Brentwood. We have one in Mount Juliet now, and we're able to serve, I think we're almost to 650 clients, and we have 18 therapists. Yeah, it's been a labor of love. It's also been a lot of labor, which you and I have talked about. But that's a little long-winded. My not so little long-winded synopsis of the clinic.
Yeah. Gosh, yeah. And I can certainly just attest to that. Yeah, it is a labor of love, both being a therapist and wearing many hats like we do. This morning, I was vacuuming and Swiffering the kitchen in our office. And then I saw a client, and then I had a meeting, and then we're doing this podcast. So I can certainly relate to just the many hats. And I'm like you in that way, where I really enjoy changing things up and kind of dabbling in different things at any given moment. But I am curious, when you are seeing someone with a new diagnosis, or perhaps they don't know that they might have OC. So for those of you that are listening, sometimes we abbreviate that, we drop the D, and we kind of abbreviate it as OC. But what is that like for them to receive that diagnosis? I'm curious as well. I think a lot of times it gets missed in the therapeutic world. And so, we are known for the treatment of eating disorders, and sometimes clients have been in therapy before and have never had treatment for their eating disorder. And I understand that that's probably similar to your experience with clients. So can you just speak a little bit more to really why OCD gets missed and what your clinical thoughts are on that?
Yes, I think a lot of people, despite there being increasing public awareness of the heterogeneity or sort of variability of OCD, the different ways that it can show up, I think there is still this reliance for many clinicians who don't specialize in OCD. There's this reliance on the presence of overt physical compulsions that are somewhat stereotypical in nature, I would say. So your classic cleaning and checking, evening things out, wanting things to be just so. And I don't at all want to invalidate those symptoms. Those are true symptoms of OCD. That's sort of the tip of the iceberg.
Sure.
And so I think part of it is that certain content areas are either overlooked or misperceived. And then part of it is that sometimes there can be mental compulsions. So in terms of areas that are overlooked, we know that one of the most common manifestations of OCD is this intrusive, unwanted, persistent thoughts of a taboo nature. So they might be thoughts of violence toward loved ones. Again, that's not, or just people in general, animals in general. And they're what we call ego dystonic, meaning they are not consistent with what that person wants to believe. It's almost like somebody just, climbs up on your shoulder and yells into your ear, like, go hurt that person. Or they can be of a sexual nature, of a blasphemous nature. It's really anything that kind of subverts your values or makes you feel like you kind of out of left field. So that's a huge category content-wise. And then, as I mentioned too, you have covert compulsions. So these can be things like mentally reviewing something over and over and over again, counting to a certain number. There are these kinds of invisible symptoms. Even avoidance itself can be a compulsion. So I that's a broad answer. I'm glad to get more into detail, but we do see it a lot. Did you have any follow-ups before I get into like what it's like with clients in the room?
Yeah, no, I mean, that all, I'm just like soaking it in as you're sharing. That all tracks and makes a lot of sense. And I think oftentimes, like the taboo piece that you shared, perhaps there is a level of shame that a client is experiencing, and they are not wanting their therapist to know that they're having this thought, or there's like the thought about the thoughts, or the meta thought of like, oh my gosh, this must mean that I'm a bad person because I'm having these thoughts, and I'm the only person in the world that struggles with this. And so there's lots of different reasons, I'm sure, why OCD gets missed or even misdiagnosed as generalized anxiety disorder, and not to discount the pain and suffering that might come from generalized anxiety disorder, but I'm sure that all of those pieces are kind of moving puzzle pieces to the equation that maybe proceeds when a client comes to y'all.
Yeah, I think that's right. That's very well stated. And then at worst, I think sometimes there are people who overcome this tremendous amount of shame and self-judgment and they disclose symptoms. And unfortunately, if they disclose them to a therapist who doesn't understand OCD, they might misinterpret these as what we would call egosyntonic or wanted thoughts. And they might kind of say things like, well, let's make sure to keep people safe from you or keep you safe. And that's feeding the intrusion, that's feeding the obsession. So we definitely need better education about that. I think it's a real honor and sort of a sacred space to be able to sit with clients who are able to bravely state, I've had these thoughts. And guess what? I've not had them once or twice. I'm having them constantly. Maybe they're having them about me when they're sitting across from me. I could get up and harm you, or what if I did something inappropriate? And I just think that there is it's so special for us as therapists to be able to hold space for that and just normalize it and say, like, yeah, that's kind of how it works. And furthermore, not only am I here to, provide space for you to talk about it, but we have some really effective tools to help you respond to those thoughts in a way that's not going to feed them.
Sure. Yeah. And I think when a client hears that, there's so much hope in that and so much empowerment. And that's a lot of the work that I know that your clinic does and mine does as well, around like cultivating hope and providing an effective treatment plan with evidence-based therapies, and really letting a client know that we're like in it with them. That's all just such beautiful work that you all are doing. And yeah, speaking to the psychoeducation, I think it's twofold. I definitely know that you all are out and about, teaching on the symptoms of OC and how to spot it if you're a therapist, or perhaps you're not a therapist and you're wondering whether you have OCD. So I definitely think the psychoeducation and increasing that is an important piece of even recognizing the OC so that you can get appropriate treatment. And one thing that I talk to many therapists about in the community is just this idea that in grad school, we don't get a lot of training on kind of more nuanced specialties. And I think that there's maybe even room for that. So a lot of the people on my team treat eating disorders and body image concerns, and we don't really get much training on it. And I think the same is true for perhaps the specialization of OC. And so I think there's maybe many areas of improvement. And I know that they certainly have a lot to teach us as we're going through graduate school programs, but it can just be a lot when you exit your grad school program and you're maybe expected to know how to diagnose all the things and how to screen well and ask appropriate assessment questions. It's like, it's so much for any new therapist.
It's so much. And then there's this further question around, well, do I want to then seek training opportunities and licensure, which provides a broad base, kind of more generalist basis, and then knowing when to refer out for specialty treatment like eating disorders or things like that? Or do I want to specialize now? And of course, all those common kind of clinical skills are going to be taught, but they're really taught within this, with respect to like depth in a particular area, which is certainly kind of how we've developed our clinic, which is, we're here to, that's why I call it a treatment center and not a counseling center, even though we have folks who stay at the clinic for, as long as it's helpful. We're not like, well, you get, 12 sessions.
12 sessions. And then you're done.
Yeah, not real life. But it is also, because it's so directive and it's so goal driven, that was important for me to have that in the title. But I think like another thing we were thinking about talking about today is ERP in particular. And I think that that is, I know I'm putting the cart before the horse a little bit, but I think there are also a lot of stereotypes about what it means to use particular treatments or what it means to do treatment generally, that it sort of misses the boat of being dynamic and collaborative and creative and compassionate and other good words that start with C, apparently.
No, yeah. And I mean, yeah, thank you for sharing. And I definitely want to hear more about your take on, I know you've mentioned providing compassionate ERP and just what that means for you. But yeah, I concur. Our practice does have counseling in the title, but we function a little bit more like a treatment center as well, as far as like the urgency around treating the diagnosis. A lot of times people come to us and there's just pretty severe or significant pain and suffering. And so we want our clients to really have a treatment plan in place and perhaps a medical team or dietitian in place so that they can really start to feel better, because I know that they're suffering. And a lot of times with OCD or an eating disorder or both, clients are really suffering. But yeah, tell us your thoughts on what the stereotypes are that you have seen around ERP. I'm so interested to hear.
Well, and I will say, I think that these notions of so first, to back up, ERP is exposure and response prevention, which is an evidence-based treatment for OCD. And it consists of gradually and progressively helping people kind of move toward things that would otherwise, that spark anxiety or would otherwise be avoided, while also reducing the extent to which people are using compulsive behaviors like hand washing or reassurance seeking or counting, checking, what have you. And so it's kind of those two things in tandem. And it has a great evidence base. But I think part of the reason that ERP gets a bad rap is because, like any other treatment, it can sort of be applied in a really heavy-handed, rigid, and uncollaborative, sort of unilateral fashion. And so a lot of times, and in fact, I just wrote an email today to somebody who kind of, they want to get treatment for OCD, but they've heard things about ERP. And the things that they've heard are, well, goodness, are you just going to make a list of everything that invokes distress in me and then sort of force me to confront these things? And I told this person, I'm just really glad you brought that up as a concern, because no, that's not how that works. In fact, I tell people when they come to therapy, which is such a brave act of self-advocacy and curiosity, they're already doing an exposure.
Absolutely.
Yeah, 9 times out of 10, the bravery that it takes for folks to show up in our offices and say, I'm afraid about this, or I have these thoughts and I haven't told anyone, that is an exposure. So I think the stereotypes are like, well, if you have contamination OCD, they're going to have you eaten off the toilet lid or the toilet seat. No, it is. Now I work with kiddos too, and sometimes we do wild out a little bit. We'll have, we'll just have there was a kid we worked with once a while ago who was talking about eating Oreos off the floor, and we called them Floreos, and we had like a Floreo
I
party.
love it.
We did it in different rooms. Okay, but like that is, if that's empowering to sort of go above and beyond what's typical behavior, sure, we can go there. Most of the time, that is not necessary for exposure therapy. In fact, for a lot of people, the way that I conceptualize exposures are, hey, what are your symptoms preventing you from doing that you would otherwise do? Period.
Absolutely.
And that might be like, for a lot of people, it's very values-based. It's, I want to get back to going to my place of worship, but I'm nervous. I'm nervous this is going to come up. Okay, well, let's do those kinds of exposures, moving you toward things. I want to be able to hang out with my little niece, regardless of whether or not I'm having these intrusive thoughts. Okay, well, let's do baby steps toward that. And so I think it's compassionate, consensual, and clear.
Sure.
Yeah.
Yeah. And I mean, I love this verbiage that you're using. And yeah, I mean, I actually did see a post the other day, and I actually thought of you because it was talking about all the problems associated with ERP. And I was kind of thinking like, wait, ERP is amazing. We actually use it quite frequently in the practice. For those of you listening, we talk a lot to clients about approaching versus avoiding, and just that psychoeducation, that avoidance typically makes anxiety worse. And so I love everything that you're sharing. And I am absolutely on board for this. And I do think that there's maybe some misconceptions that sometimes can be fueled, I think, in a negative way by social media or all of our accessibility online. But yeah, the consensual piece, the clear piece, the collaborative piece, and And also, I think that you guys do a great job around providing psychoeducation, like what ERP is and why we do it, to face those fears so that we can lead a more meaningful and values-based life. I mean, all of that, I think, makes a lot of sense to me. And if I were a client, that would make a lot of sense to me too. Something that we see in the practice that we're consistently encouraging our clients to approach is, maybe perhaps a food that they've avoided for a long time and they want to be able to go out to get pizza with their friends. Or we see quite a bit of social anxiety in the practice. And so really looking at, I want connection with other people and I want to experience belonging. And I know that I need that to lead a meaningful life. So doing values work with clients, I think, is just such a rich part of our work.
Yeah, I agree. And I will say that ERP, it's very rare that any clinician who's really clinically minded and not sort of just a technician is not doing a treatment like ERP. For me, is very compatible with a lot of other treatments.
Absolutely.
Cognitive work, motivational work, values work, mindfulness work. And so I think there is this understandable tendency, sometimes especially in social media and so forth, to kind of look at the bare bones version of exposure and response prevention and think about just doing it in a vacuum. And my whole, something that's very important to me is I recognize the trust that it takes and the therapeutic relationship that it takes as a groundwork for helping people to challenge themselves. And in fact, we have some people who come in and the issue is they have OCD and they're challenging themselves too much. They're out there gritting through it and then beating themselves up and doing compulsions and this and that. So I say that to clarify that, all of these sort of like evidence-based practices can be woven together and can be individualized. So you don't just come in and it's like, well, here's worksheet number 1, or I know some clinicians will say things like, well, do you want to do ERP or do you want to do metacognitive therapy or do you want to do inference-based CBT? And it's sort of like, well, why not integrate what's going to work best for you instead of sort of this forced choice that's very rigid.
Absolutely. Yeah. And it sounds like you're doing what we call motivational interviewing and ERP and perhaps some CBT and perhaps some acceptance and commitment therapy. Yeah. I love that. And each human being is so unique and so their story is so unique as well. So of course we're going to, hopefully an effective therapist will individualize their treatment plan and want them to be a part of creating that, because that is that consent piece that I think is so important in our work. Yeah. Yeah. Are you open to sharing a little bit more about your thoughts on the intersection of eating disorders and OCD? You know that at Anchored we see a lot of presentations across the spectrum of an eating disorder diagnosis. So I know that our listeners might have disordered eating or body image concerns, or may have received an eating disorder diagnosis. And we're also here to say that if you have a concern about your relationship with food, or perhaps you are wondering whether you have OCD, no matter whether you've received a diagnosis, you're deserving of care and of support and of taking that courageous step, like Amy mentioned. But I would love to kind of hear your thoughts on the intersection of those two diagnoses.
It's so fascinating because I think, Laura, it's like there's sometimes there's a clear boundary, or a clear demarcation between like when is something an eating disorder, when is something OCD. And I'm particularly interested in the kind of like the murky middle. And so things like orthorexia, which is not a DSM diagnosis, but is this presentation of frankly, obsessions about eating clean, eating healthy, et cetera. They may or may not be tied to body image. Of course, if they're tied to body image or shape or size, I'd be more likely to sort of kick it over to an ED diagnosis. But in OCD, we often see it as like a prevention of internal contamination by, processed foods or things that aren't organic. And it it can escalate to a point where people are really restricting. And again, it may not be, it's based on health rather than body
Sure.
image. It can be a little bit of both. So that's one overlap. I mean, I think with anything, so we've worked with people who have binge eating disorder for whom the OCD almost becomes enlisted in the binging. And so it's like, well, I'm binging, and then but I can't stop until it feels right, which is not tied to actual like satiety or body cues. It's tied to this sort of just right feeling. Um, and I think just generally there is this subtype of sort of like a common personality factor of perfectionism, or tying one's worth to things being, I will say air quotes, perfect, because that's not a thing, but this kind of moving bar of perfectionism, so I'm striving, and then I don't, and then I meet this goal, and then I'm striving harder and harder. And so, yeah, any follow-ups on that? I know I went sort of all over the map.
No, I mean, I'm with you. I think that kind of thread around perfectionism, and just that thread too around avoidance, that is something that we are talking quite frequently about, in our staff trainings, and of course with our clients as well. And it seems like that's a lot of the work that you all are doing. So that's the word that really stood out to me as you were talking, was just that common ground of, and again, I know there are different diagnoses and they have different kind of presentations and manifestations and all the things, but there is that thread, I think, of avoidance, whether it's rooted more in OCD or rooted more in fear of food, or avoidance of an emotion, but they can kind of show up differently. But I do think that's a commonality between the two.
I love what you just said as well, that idea about avoidance of emotion. And I know in acceptance and commitment therapy, that's bafflingly often called experiential avoidance, which to me is not intuitive. I'm like, I guess it is an internal experience.
Yeah.
It isn't for either eating disorders or OCD. It is not always this external feared outcome, right? It's not always this idea of, for OCD, if I don't do X, Y, and Z, then something bad is going to happen. Sometimes it's, if I don't do X, Y, and Z, or I don't do it just so, then I'm going to feel so overwhelmed and so distressed, so distraught. I'm not sure if I'll be able to handle that. And so
Yes.
It goes back to what we were saying too about integrating different therapeutic modalities. So people sometimes need a little bit of like distress tolerance skills, again, from DBT or things like that, so that they can sort of weather. I would use your analogy here. They're weathering the storm, right? Their anchor is, I am practicing weathering this storm, and I have some skills to do so. So it's not just like, well, that scares you, go do it. No, if that were true, you would have done it. I mean, most people with OCD are like, I don't want to live like this. They would have done it. So we help sort of scaffold and so forth.
Yeah, absolutely. Yeah, and I just am with you on that. And I do think that emotion piece, and even like myths that I believed about emotion before I started my own therapeutic journey a while ago. And so really working through some of those myths with clients, I think can help them perhaps be more successful at doing ERP. Just this kind of idea that I can handle hard things and I can tolerate being uncomfortable. We are absolutely doing that work with clients in our practice, whether that's tolerating fullness or resisting the urge to engage in an ED behavior. It's similar in that way to OC. Like, I can tolerate being uncomfortable, and we need repeated kind of practices around that to be able to trust that we can tolerate it. So yeah, I love that work.
Yeah, that is so well said. I don't know if that has been an affirmation yet about tolerating uncomfortable.
Yeah, we can have that. What would you say is the affirmation?
Yeah, I can tolerate whatever uncomfortable internal sensations arise as I'm working toward living a life in accordance with my values. I'm wordy. If y'all want to like make that shorter, that's fine. But
I love it. I'm here for the wordiness, and I just think you're so wise, and so I love it. I'm curious, how can our listeners find you? Any last kind of nuggets of wisdom that you would like to leave today on the show?
Well, as far as nuggets of wisdom, I guess I would just say if there's anybody out there who is hearing, parts of themselves in the kinds of things that either one of us are saying, and they've been reluctant to explore that or afraid to explore that, it's never too late to get into therapy or start doing some of that self-exploration. I know, again, I said my symptoms started probably around age 6, and I was diagnosed with OCD. I want to say I was 24. So, and you can read some scary research that says things like, well, the longer time that has elapsed between appearance of symptoms and effective treatment, the worse the outcome. And, there's correlations, and it's never too late. It might take a little bit longer, or it might not. I feel like for me, there was this light bulb moment. And so that's what I would say in terms of just something final that I want to say. And then as far as finding us, we're in the Maryland Farms area of Brentwood for our clinic, for those of you who are local to the sort of greater Nashville area. And then we have a location as well in Mount Juliet. And so that would be sort of physically where to find us. Online, we're ocdnashville.com. On Instagram, it's OCD Nashville. And I also have a book about thriving in relationships when you have OCD. So kind of looking at the more relational aspects of OCD. And that can be found on Amazon or with my publisher, New Harbinger.
Amazing. So I have two things I want to say. First, if you are not following OCD Nashville, I feel like I repost every single one of y'all's posts. I'm like, I promise I'm not stalking y'all, but they're so good. And Amy actually you do the drawings, right?
I do. So I've been a little bit remiss. I haven't been as active, but yeah, I do some little digital comics in an effort to render some pretty complicated, I think, mental health concepts into like digestible nuggets. So you'll see those there as well.
And it is phenomenal. And I have personally read Amy's book. I cannot recommend it enough. I know that we recommend it to many clients in our practice. So please look Amy and her practice up. We're so glad just to have you today. And I know Lauren says hi. But yeah, thank you for your time. And as we close, is there any homework that you would like to give our listeners for them to kind of marinate on or think on after the show?
Yeah, let's see. One I think now, big caveat here, seeking reassurance from others is something that we often do in relationships. It is a normal part of life. It's also something that we do if we have a lack of information about something. So if I'm not sure about whether or not it's safe to go on a hiking trail without having, whatever, those ice spikes for snow, right? That's a reasonable question. Now, if I ask an expert that, somebody who's been on the trail over and over again, they say, you don't need it. And then I seek out 3 or 4 more people. Okay, that might be sort of compulsive reassurance. So what I would challenge folks to do is think about, do you ever find yourself asking for reassurance that is truly just sort of to assuage anxiety instead of in the service of getting new information? Just notice that, be curious about it. Many of us do it. Many of us who are people pleasers do it more than others. But if that is
me,
here we are. But be curious about that. And then the homework is, after you've sort of developed an awareness of that, see what it's like to maybe try to resist that. Does it stick around forever, or does it sort of fade over time and help you develop a greater sense of sort of trust in yourself?
I love this homework so much. And yeah, I have personally worked on this in my own therapy. And I'm here to say it's not necessarily easy when you start, but this is why ERP works, right? Is to really build that confidence in ourselves and to build that trust in ourselves. So thank you, Amy, for your time today. I know that your time is so valuable, and we're just so grateful to have you on the podcast. And I would love to have you back. Perhaps we can have Lauren with us next time around, but we would love to have you back just to learn more from you moving forward. Thank you.
Thank you so much. Appreciate it.
Bye.